now going to talk about a mental health provider, a therapist type. That could be a psychologist or an LICSW, which is a master's trained social worker in psychotherapy. We have both providing services in nursing homes. And what we have learned over the years, it is much better to come to the facility than send an older adult out for an appointment. It saves the health plan a ton of money. If you sent, like this morning at a nursing home, I saw 5 clients. If you sent them to me here, there'd be a charge for transportation here and back times 5. That gets expensive very quickly when you have 50 providers. So it saves a lot of money, and it also saves money and headache for you as a facility that you don't have to send a staff member along to the appointment. Everybody wins. The other part, many of our clients, particularly in skilled nursing, have dementia and can't tell their story or their symptoms. And so we have to get the data from the medical team, physician or nurse practitioner, even more important from the nursing assistants and from the nurses and social worker. What is it that's going on with this person? Then we have to think about what are the antecedents and what do we know psychologically, and then putting a plan together. There have been some mental health providers, not in our group, that go into facilities and won't share anything with the staff. To me, that's a waste of time and a waste of money and a lose-lose. We want to share things with the facility, and we want to help people feel better sooner and reduce human suffering sooner. And we believe as a team, therapeutic rec, social service, nursing, dietary, medical, and psychological within the psychosocial context can create a better outcome for people, unfortunately, end up in a skilled nursing facility. Now I say unfortunately because if you look at the data, 99% of Americans say, whatever you do, don't put me in a nursing home. So we have found what's best is to set up a regular schedule, like tomorrow morning at 7:30 I'm going to be at a nursing home. I personally have gone to that nursing home for 42 years every Friday. And tomorrow when I get there, I'll be meeting in a room, conference room, with the administrator, assistant administrator, DON, ADON, the clinical nurse managers, the social worker and director of TR, and we will go over any new referrals and we'll go over my caseload. You know, we'll go over Betty Doe, Tommy Doe, Jimmy Doe, Sammy Doe, and we'll probably go over Tony Doe again too. But those Does were really a difficult family. I think they came from my neighborhood on the east side of St. Paul, but I'm not quite sure. And then I sometimes will talk about things, some research maybe I'm doing or something I testified in a court case, and share that. We pass a spreadsheet around with all the clients' names on it, and everybody in that room signs off on it. And if I start talking about a theme on professional boundaries, how to manage antipsychotic medication and non-pharmacological approaches, for instance, to screaming or whatever, or how to document a way that you're not raising red flags to auditors or surveyors. That theme is written on that page too. We usually meet for about a half hour. Everybody signs off. So when the health department comes and says, under the rules of participation, where a facility has a responsibility from federal statute, you have to improve the behavioral health of your residents. Well, here are 52 sheets of paper showing these clients were discussed. It was an interdisciplinary team, and we even talked about other things. And you also, as a facility, as you well know, have a mandate to improve the behavioral health competence of your staff. We're already meeting in there to everybody from different disciplines talking about the Doe family, each one of them individually. There's training in that. So that is 52 signatures of what has been done at this facility to improve the behavioral health of residents and improve the behavioral health competency. It doesn't take any more time. It's using the time and documenting the time that you are checking off at least 2 statutes under the rules of participation. We like to come on a regular basis, either weekly, every other week, with the longest duration would be once a month. Communication with the staff is essential, and once again, we very much love what we do. We have passion for these underserved residents and for the staff who choose to work with them. I was interviewed a couple weeks ago and said, "How is it you're still doing this? And what keeps you going?" I said, "I get up every day because I want to be a voice for those that don't have one. And I want to help people that end up in these buildings to have a better experience. And I want to help, thank God, we got staff who choose to work with them. If I can make all of that better, the patients better, the residents better, and the staff are more satisfied and hopefully want to stay in long-term care and care for this special population that are tremendously underserved."